Good evening and welcome to the Cardiovascular Innovations webinar to an approach to patients with polyvascular disease, a concerted approach to improve outcomes. Welcome you all, and I'm Dr. Subhash Banerjee, the host and moderator. I have the distinct pleasure of inviting three of my esteemed colleagues and faculty members who will be presenting their thoughts in this webinar. Let me introduce you to them and also say a few words about the webinar itself. It is a CME accredited webinar. The learning objectives include identification of the residual risk in patients with polyvascular disease, the role of Pcsk9 inhibitors and antithrombotic therapies in this group of patients, and establishing a integrated, viable, multidisciplinary team to address the patient's needs with peripheral arterial disease, and finally, discuss some avenues of future research that is groundbreaking in our field. First of all, let me introduce Dr. Tony Gutierrez. He's an interventional cardiologist at Duke Health at Durham. Dr. Taran Hamad, who is an assistant professor at Case Western. He's also an interventional cardiologist at the University Hospitals in Cleveland. And Ian, my ex-colleague from UT Southwestern and now the proud faculty at Case Western, who is also the director of cardiovascular prevention and a co-director of the Center of Integrated and Novel Approaches in Vascular and Metabolic Diseases. And I think I want to invite them all and thank them all for sharing this evening with us. And I'm sure you will love their presentations because I'm really, really excited to hear them and quiz them with some very difficult questions, I guess, and cases and situations. This CME webinar would not be possible without the commercial support of Abbott Vascular, Boston Scientific, and Medtronic, who have provided commercial support for this education activity and again helped us bring these webinars to you over this last year and in 2022. To claim your CME credit, you can easily get the certificate and complete the survey at our website, cvinnovations.org. And again, our organizers and our staff at CV Innovations will share this link with you for you can print and download your CME certificates. Two announcements. Our next webinar will be on June 2nd, 2022. Again, 9 p.m. Eastern, 8 p.m. Central. It's going to be on how to optimally use intravascular coronary imaging and coronary physiology. Dr. Manos Berlakis would be, my dear friend, will be leading that webinar as the moderator. And of course, not to mention the CVI 2022 live in-person conference in Denver, June 21st to 23. So please register, send in your cases for case presentation. And of course, I invite you all to apply for travel grants and bridge grants for both faculty, early career faculty, fellows in training, residents, and of course, cath lab staff and nursing personnel. So with that, I just want to invite Dr. Ian Nealon to share the slides. And again, the entire content of the webinar is being recorded and will be available at www.cvinnovations.org. Ian, the floor is yours, and I invite you to talk on Pcsk9 inhibition and antithrombotic therapies.
Okay, thank you so much, Dr. Banerjee. It's a pleasure to be here tonight to speak with everybody. Could everyone see my slides okay? Okay, fantastic.
Good.
So I have a tall order tonight to speak on the role of Pcsk9 inhibitors and antithrombotic therapies in patients with polyvascular disease. To start off any discussion of novel therapies, especially in patients with polyvascular disease and multiple comorbidities, one has to understand the context of the therapies within the context of the risk. And certainly patients with polyvascular disease are at elevated risk, not only for major adverse cardiac events, but also for major adverse limb events, such as need for limb revascularization and occasionally amputation. Now, as the risk increases across the number of arterial beds that are involved, certainly the benefit of novel antithrombotic and lipid-lowering agents also increases. And that's where we come to two important classes, which I'll speak about tonight, Pcsk9 inhibitors for lipid-lowering therapy and antithrombotic therapies, both including antiplatelet and anticoagulant medications. So let's start off with the PCSK9 inhibitors. Just a refresher for those of you who are unfamiliar in the mechanism of action of this novel class of medications. What happens is that secreted PCSK9, there in that gray circle, binds to the LDL receptor that's on the surface of the hepatocyte. And the LDL receptor is involved in binding LDL particles from the bloodstream and bringing them back into the liver for recycling. And what happens is that the PCSK9 binds to these LDL receptors, targets them for degradation in the lysosome. So you end up with more PCSK9 equals less LDL receptors, which then turns into greater amount of LDL cholesterol circulating in the bloodstream. So what PCSK9 inhibition does is it allows more LDL particles, LDL receptors to be at the surface of the hepatocyte, so we're able to grab more LDL particles and decrease LDL cholesterol content. Now, the efficacy of PCSK9 inhibitors has been seen now in multiple trials across multiple medications. What I'm showing here is a pooled analysis from two medications, both monoclonal antibodies for PCSK9 inhibitors. And this was studied both in populations with heterozygous familial hypercholesterolemia and patients with clinical ASCVD. And in both medications across different doses, on background statin therapy, we see about a 60 to 70% reduction in LDL cholesterol in addition to the statin therapy. So very robust medications and certainly across high-risk individuals. So the question is how does that play into patients with polyvascular disease? Well, this was studied in the Fourier trial, sub-analysis. The Fourier trial was a trial of evolocumab in patients with atherosclerosis on background statin therapy. In this trial of 27,564 patients, a little over 3,600 of them had symptomatic lower extremity PAD. Of those, 1,500 or so had only PAD without prior MI or stroke. So over half of the patients with PAD had polyvascular disease, including either coronary or cerebrovascular polyvascular disease. The breakdown of the study population here is shown here. And so you have a lot of folks who had intermittent claudication with abnormal ABIs at baseline. Many others had peripheral revascularization, and certainly there was an overlap. And about 4% had a history of amputation for ischemic peripheral arterial disease. So a high-risk population, certainly. Now, what we saw in this trial was that the main analysis of Fourier showed that there was a 15% reduction in major adverse cardiac events in the overall population. And in this sub-analysis, 13% of patients had PAD, and it was stratified between PAD and no PAD. And what the authors found was that those patients with PAD, again, remember, over half of them had polyvascular disease, had a 4.1% absolute risk reduction with a number needed to treat of 25 with evolocumab on background statin therapy, compared to those without PAD who had a 1.5% absolute reduction. And so even though the relative risk reduction was generally similar between those with and without PAD, those who had PAD certainly had a trend towards greater absolute risk reduction, both in MACE and major adverse limb events, with a lower number needed to treat with evolocumab plus statin compared with statin alone. Now, what's interesting in this analysis is that why does PCSK9 inhibition have a greater impact potentially, or impact at all, on polyvascular disease? This is an analysis of alirocumab that was recently published, currently online last month, that looked at 300 patients, 2% of them with PAD, and they were randomized to either alirocumab versus placebo on top of rosuvastatin 20 milligrams on background. They were enrolled less than 24 hours after an urgent PCI for acute myocardial infarction, and they were studied with multi-imaging modalities. They were studied with IVUS, infrared spectroscopy, and OCT. They did this at baseline and then follow-up after 52 weeks of treatment on either the alirocumab or placebo with background statin. And what they found was that the PCSK9 inhibitor had greater reduction or regression in coronary plaque in non-infarct related arteries. you can see here that from baseline on the top, compared with plaque imaging at 52 weeks on the bottom, the percent atheroma volume decreased significantly, the maximum lipid core burden index did the same, and the minimal fibrous cap thickness actually increased, suggestive of this more stabilized plaque. So at least this gives us some understanding in terms of plaque characteristics and integrated biology through imaging, how PCSK9 inhibition can impact the vascular bed. Now let's move on to the role of antithrombotic therapies in polyvascular disease. We do know that antithrombotic therapy is certainly a pillar of optimal medical treatment for patients with polyvascular disease, be it with aortic or peripheral arterial disease who are at very high cardiovascular risk. Now, the guidelines currently say that long-term antiplatelet therapy is recommended for carotid artery stenosis, severe complex aortic plaque or an acute aortic syndrome, symptomatic peripheral arterial disease, and atherosclerotic renal or mesenteric artery stenosis. And the guidelines also say that very low dose rivaroxaban plus aspirin can be used for high-risk patients, those with polyvascular disease, or after peripheral revascularization in those patients. So let's take a closer look at some of these classes of medications and their impact specifically in patients with polyvascular disease. This here is a secondary analysis of the COMPASS trial, which I'm sure everyone here on the call is familiar with. And this looked at patients with stable vascular disease. In the overall trial, 24% reduction in MACE was seen. This particular analysis looked at patients stratified by the REACH or CART scores, which essentially divides patients between less than 2 or at least 2 or more vascular beds affected by atherosclerosis. And in this case, 25% of patients had polyvascular disease in this study. And what they saw was similar to what I've shown with PCSK9 inhibition, was that those with very high risk features in polyvascular disease had a greater absolute risk reduction at 30 months with anticoagulation of low dose rivaroxaban 2.5 plus aspirin compared with aspirin alone, such that those with polyvascular disease had an absolute risk reduction of 3.64 versus an absolute risk reduction of 1.09 in those without high risk features or with single vessel disease. So again, you can see a greater benefit potentially with those with polyvascular disease with rivaroxaban plus aspirin compared with aspirin alone. Interestingly enough, a similar analysis was seen in another trial, the Pegasus TIMI 54 trial, which included 21,000 patients with prior MI randomized to ticagrelor versus placebo on a background of aspirin. And in this study, 2 things come to light. First of all, the graph on the left. What this is showing is that patients without PAD had an overall lower rate of CV death, MI, or stroke compared to those patients with PAD in the trial, pooled in terms of pooled numbers of cohort. In fact, adjusted hazard ratio for having peripheral arterial disease was 1.60 compared with those without. And what they saw when they stratified by having PAD, yes or no at baseline, was that again, the absolute risk reduction for patients with PAD using ticagrelor plus aspirin versus aspirin alone was 4.1% compared with 1% of those without PAD. So even though, again, the relative risk reduction or hazard ratio was similar across the 2 groups, those with PAD had a much greater absolute risk reduction and benefit with a lower number needed to treat with dual antiplatelet therapy compared with single antiplatelet therapy alone. And finally, the last trial I'll talk about was the trial of Vorapaxar. This was the TRA2P TIMI 50, one of the toughest trial titles I think there are, which was over 26,000 patients with stable atherosclerotic disease that was randomized to Vorapaxar versus placebo. As many of you know, Vorapaxar is a novel oral antiplatelet agent that antagonizes the activation of PAR1 by thrombin. In the overall trial, there was a 13% reduction in MACE in the secondary prevention population for established disease. And in this particular analysis, they looked at 3,700 patients with claudication plus an abnormal ankle brachial index or a history of prior peripheral revascularization. Now, In the overall trial, Vorapaxar, not in the overall trial, but in this particular analysis, Vorapaxar did not reduce the risk of CV death, myocardial infarction, or stroke in patients with peripheral arterial disease. But what we do see in this sub-analysis, and again, this is a sub-analysis, post-hoc analysis, but that patients with hospitalization for acute limb ischemia, the risk was much lower with those on Vorapaxar compared to placebo. And similarly, the risk for peripheral revascularization was lower on Vorapaxar versus placebo. So again, more intensive therapy, in this case with a novel PAR1 inhibitor, was shown to improve peripheral outcomes essentially in patients with polyvascular disease. So just to finish off, this is a very nice algorithm of how to integrate this data and understand it a little bit better. This comes from Hess and colleagues out of Circuit Interventions in 2020. And what it says is consistent with the guidelines, in that patients with peripheral arterial disease should be differentiated into those in the acute setting of peripheral vascularization compared to the chronic stable setting. Now, those with acute peripheral vascularization, that's where your COMPASS trial comes in. That's where low-dose rivaroxaban plus low-dose aspirin can be helpful. And certainly, that's the direction we usually go. Among those with stable atherosclerotic disease, and obviously those with polyvascular disease, often it's important to differentiate those individuals between a low and a high bleeding risk. Certainly those with a high bleeding risk, you'd want to avoid multiple classes of agents. So in this case, monotherapy with aspirin or clopidogrel would be an appropriate indication. And those with low bleeding risk, then it kind of depends upon their ultimate outcome risk, whether it be for MACE or major adverse limb events. And so those with high risk can be considered for novel agents such as dual antiplatelet therapy or low-dose anticoagulation with aspirin. And similarly, those with high limb risk can be considered for the same. So I'll stop there and take any questions and discussion. And I hope that's been helpful for those here on the call.
Ian, fantastic. I've never seen such a whirlwind tour of all the evidence. And I think you raised certain very provocative points. I just going to ask and maybe focus on one. I also invite all the attendees. There are over 50 attendees on this webinar right now, but invite attendees to not give our esteemed speakers a pass and challenge them with some important questions, because it is sometimes quite hard to interpret this evidence and apply it to a singular patient that is sitting in front of us. And I think we'll bring some of those case scenarios at the end of the webinar. Ian, I have one question for you. You know, to be honest, had not seen that online publication about near-infrared spectroscopy and regression based on IBS and OCT. Is that your assumption or contention that something very similar could be happening in the non-coronary, extracoronary vessels?
Yes, I do think that's likely. I do know that the pathophysiology between the two vessel beds are different. And I would love to see similar research done in the peripheral arterial system. But what I think is important is that the PCSK9 inhibitor, the mechanism of action is such that it really dramatically lowers circulating LDL cholesterol. And so if although it doesn't attack the thrombotic aspect of it, but it might certainly attack some of the inflammation and some of the oxidized LDL and such that can get into the walls of the peripheral vascular bed. And so I think the research is ripe to look at some of this as a potential mechanism in those with polyvascular disease and PAD.
Fantastic, thank you. I have an online question for you, Ian. Where does the Voyager fit in? And those are probably more specific to patients post revascularization, but I think that in terms of its overall impact, I hope you'll agree that it does have a secondary prevention role in patients who are undergoing revascularization, especially lower extremity endovascular intervention, both surgical. Actually, Voyager was unique in the sense that it did include both surgical and endovascular patients. And And a contingent of patients in that, about 30% were actually treated open label with clopidogrel in that study and didn't impact the outcome. So any other comments that are worth you would like to highlight from the Voyager, Ian?
The algorithm that I showed there at the end touched upon that study in the sense that those who've undergone acute peripheral limb revascularization, low-dose rivaroxaban with background of aspirin can be beneficial in those patients. And I do think that's a high-risk subset that we should really try to be aggressive with doing this type of strategy for. I think there's a lot of clinical inertia, certainly in the sense that a patient will come in, get revascularized, and then be discharged. And so there's an opportunity in a window there that we can really be aggressive. And I think I'll just plug in for preventive cardiology. That's an opportunity where folks like myself, preventive cardiologists, can really make sure that in a subsequent setting, the ambulatory setting, the patient's residual risk and secondary prevention is not missed. And that's an important aspect of that.
Thank you. Any comments from our colleagues on the faculty panel?
Ian, I just want to say that was a fantastic presentation. And I think you highlighted, number one, how high risk patients with polyvascular disease are, but also how effective these therapies are, probably because they're so high risk by the small numbers needed to treat. I have a question. In your opinion, you're at a large major academic institution, and unfortunately, not a lot of our colleagues watching have a preventative cardiologist. Where, in your experience, where have you seen the addition of these therapies, such as low-dose rivaroxaban? Is it more after an intervention, or are you seeing that maybe more cardiologists are more comfortable implementing these therapies in the ambulatory setting?
I do think it's more after an intervention, because that's when the acute setting and the high risk setting is most apparent. And I think once a patient goes to the outpatient setting, there is some clinical inertia there. And also there's a concern to over medicate and such. And I really think that we need to properly risk stratify and then be aggressive where we can and where we should. And the outpatient setting is one of those situations where there's a big opportunity there. So, as someone who's not in the cath lab and who sees folks after they come out of the cath lab into the clinic, I really think it's important to take a second look, understand, the acuity of the situation they were in, and treat them concomitantly.
Thank you, Ian. We'll leave it right there and get back to you in similar discussions towards the end. I would like to invite Dr. Taran Hamad. I think the reason we invited him, and not just because he's an awesome speaker, has published some awesome articles on interdisciplinary and multidisciplinary care, but he's actually been on the transition as a trainee, as an interventional fellow, and then transitioning as faculty at Case Western, and has seen how sometimes this multidisciplinary team that involves surgeons, vascular medicine, cardiologists, and others works. And maybe Hamad will share some insights when it doesn't work and how to make it work. So Hamad, take it away, and really, really eager to listen to your talk.
Thank you, Dr. Banerjee and the CPI team for the invitation. Good evening, all. Tonight, I'll be talking how to establish a viable and integrated multidisciplinary team to manage patients with critical ischemia CLI. Little background about CLI prevalence and prognosis. In 2010, which 12 years ago, it was estimated that PAD would affect about 200 million people. CLI, which is critical limb ischemia, represent about 1 to 3% of the PAD population, and those are patients with severe ischemic rest pain, non-healing wound, or gangrene. In fact, it's estimated nowadays that about 3 million Americans suffer from a critical limb ischemia. The outcomes are very poor. At 1 year, only half of the patient would stay alive with preserved limb. So a quarter would die and a quarter would lose their leg at 1 year. To put things in perspective, this is a paper published, where basically they look at the incidence of CLI and 22 other types of cancers per year, and the 5-year mortality. And you can see that CLI's incidence is high, more than 100,000 a case per year, and the mortality is pretty high. Actually, in fact, when they compared, it was that more CLI in new cases when followed over a 5-year period dies than any other type of cancer except for lung cancer. I mean, this is to least to say scary. This is, amputation heat map over US. Dr. Goodney had shown that over half of 20,000 plus Medicare insured patients with PAD who underwent a major amputation never had a diagnostic angiogram or revascularization in the preceding year. In fact, there is diabetes-related major amputation every 32nd worldwide. This means probably for the last 20 minutes, probably there have been maybe 40 amputation already. This is another paper published by Dr. Rönecke from Germany. Similar analysis had showed that over a third of 4,000 plus patients did not have any sort of vascular testing in the 2 years preceding their amputation. So before we talk about the multidisciplinary team to take care of a patient, we need to correctly identify these patients or at least have them referred. Unfortunately, many times critical limb ischemia is overlooked and misdiagnosed because if ischemia is not even differential, we have to keep in mind that CLI can start as a burn, dropping hot chocolate, trauma, etc., pressure ulcer. But if we don't have high suspicion, we'll miss diagnosis. So it's very important to keep high clinical suspicion. Early referral, early detection are key for success. And before we talk about how to build a team. So solution, of course, CLI patients are very complex. They have many comorbidities, as we all probably have come across a CLI patient in our training. Those patients are very comorbid. They're smoker, they have wounds, infection, uncontrolled diabetes. They have poor social support. They cannot afford medication. They have poor follow-up, etc. So it takes really a village to take care of these patients. Those are all teams that might be possibly involved in their care. But of course, there are some core specialties, interventionists, whether it's vascular surgery, IR, or interventional cardiology, plus podiatrists, but all other specialties might be involved at some point of time, or at least need to be involved. So how to build a CLI team, there are a few bullets for success. Basically you need to have a buy-in from all stakeholders, including hospital administrators and treating and referring providers. And how to get this is by educating them about the disease and the impact it has in the community. So this way they can provide with resources for success. You have also identify a champion physician who's dedicated and committed to treating such patients. Then you have to identify team members, which other passionate physician across different specialties to form a team, and that team has to be available 24/7 and 7 days a week, basically. You have to have an algorithm and protocols in place, when to activate, how to activate, who to reach out to, what kind of testing to start, follow-up, etc. Also, we have to have not just local, but regional system of care. As it's not easy for every single hospital, to have a CLI team, and have like, 10 different specialties involved in patient care. So maybe similar to STEMI networking, where we have maybe, hub and spokes. So the hub would be the state-of-the-art primarily treating center, and the smaller community hospitals around will be more like they can offer some treatment, but probably more serve as referring centers. Lastly, you always have to have a quality committee and scientific review committee to review cases and periodically, try to find opportunity for improvement, maybe enroll patient registries, clinical trials, and to track the long-term, mid and long-term outcomes. So, according to the PAD guidelines, revascularization remains a mainstay of treatment. So it's a class 1 societal, class 1 indication per all societal guidelines. More importantly, as you see in the second part of the table, an evaluation for revascularization option should be performed by an interdisciplinary care team before amputations in patients with CLI. As you've seen from my first few slides, that 50%, half of the patient was not even referred to an angiogram. What about revascularization? So here's our experience at the UH. Is very unique. I would like to talk about it. We published this, this year in the CIRC. intervention journal. So basically, across our integrated healthcare system, which has about 10 acute care hospitals, we prospectively, studies the implementation of a novel system-wide interdisciplinary team called LSAC, Limb Salvage Advisory Council, and its impact on patients who are already scheduled for major amputation. So those are critical limb ischemia patients. They're already scheduled by somebody to undergo major amputation. How the system work, as a treating physician, knows and elect to activate this limb salvage advisory council. Then a coordinator activates a team. It will be a virtual meeting. One of the team members will prepare an audio-visual presentation. Team would meet usually within 24 hours, maximum for 8 hours, would review all relevant data, starting with functional status, comorbidities, how extensive the tissue loss, images, studies have been done, what other revas have been in the past, etc. And this team is unique, and most unique because it does involve multiple procedures from multiple specialties. So it's not just interventional cardiology. At our institution, we share this with our vascular surgery colleagues. And not just one physician from each specialty. In one call, we'd find maybe 3 or 4 interventionists, cardiologists, and maybe 3 or 4 vascular surgeons. So you would benefit from the patient would benefit from the wisdom, experience, and skill set of all of these, individuals. And of course, at the end of the discussion, one of the 2 consensus would be reached: either yes, proceed with major amputation, no options to be offered, or this patient may benefit from advanced revasc, foot reconstruction, some advanced therapies. So in the, for this publication, we had about 19 patients in 6-month period during 2019. And out of this 19 patients, 3 patients were deemed to have non-salvageable limbs. And basically they proceed with their amputation. They all got BKA. The 16 patients left, 2 died and 2 lost to follow-up. So basically we had 12 left, 1 underwent unsuccessful revasc and up with AKA. But the 9 left actually all had limbs saved. So only 2 BKA and 9 limbs saved. This is a huge success for somebody who had already scheduled to undergo major amputation, we're talking. And also we had significant wound healing rates as well. So again, what's unique about this, there have been multiple studies that showed that multidisciplinary team improve outcomes for such complex patient. But I think 2 points, here are unique. One is that this is a prospective analysis. And point number 2, as I already mentioned, that this is, multiple interventions from multiple specialties and, multiple physicians within the same specialty as well. So it's collaboration. So to conclude, to launch a successful interdisciplinary CLI team, you would need to have a culture of patient-centered cooperation, education, mutual trust and respect among various specialties rather than competition and judgment. And to maintain this, you need committed and dedicated team members as well. Thank you so much, and I'm open for any questions.
Tariq, I'm sure that's a fantastic talk, and I think I've seen this before in your publication. Very impressive. I'm sure many of us have a lot of questions on this because it is aspirational, but it has its own challenges. I'm sure you will not deny them. Can you, without giving out institutional secrets and not making Mehdi absolutely mad at you, but can you share some of the challenges? Because it seems highly streamlined, and I can tell you that it is likely doesn't always work in a streamlined fashion. So what are the major friction points that you have seen as a trainee and as a young faculty where this team has both logistics, patient triage, image sharing, and other challenges that would preclude such collaboration that you have developed, and how have you overcome those?
Thank you. Very good question. So I think the major challenge, honestly, is the referral. And this arises, it's most of the time across a primary care physician, who do not have the enough experience, to understand that, that as I mentioned, that every non-healing wound should be treated as ischemic till proven otherwise. So unfortunately, a lot of times we either don't get the referrals or we get them very late, whereas basically there's no options for revas. It's just too late, and there's extensive tissue loss, and it's just, there's not much option left. There are some, of course, some technical challenges, but I think those are, sometimes because, the nature of the work, right? Not everybody is able to join, but I would say, most of the meeting, at least, 2 from each specialty for interventional cardiology and vascular surgery are on the meeting. So 4 proceduralists. So this is, in my opinion, a huge success, to have such collaboration in a timely fashion to serve the patients. This is really huge.
Thank you. I think there is a online question. Does this at your place happen only at an institutional level, at a university setting, or you think this can be implemented in OBLs or practices that do not have large hospital settings, like referring to what Tony asked of Ian, where such a multidisciplinary team may not be always easy to assemble?
You're absolutely right. It all depends, at least at our, we have the primary center, which is the Cleveland Medical Center, but we also have, community hospitals, and this LSAC applied to all, to all the hospitals across the system. Now, for other, hospitals, it depends whether in this city or other cities, it depends on the resources, and do they have vascular medicine specialists? Do they have procedure for one specialty versus the other? So it may not be, easy to assemble such team. In fact, we have a smaller health system in towns that, a lot of times, because of our reputation and because of the success of this program, we have got many referrals from them. I would say at least in the last 6 months, I think we got 2 or 3 cases where, they said, there is nothing else we can do. Can you help us?
If you can unshare your slide, Tony will share. In the meantime, I think Ian has his hands up. Ian, you can ask Tarek your question or make a comment.
Yes, hi, Tarek. Thank you so much. I do have one comment and one question. One comment is being at the same institution and seeing this in action, I can definitely testify to the fact that it works really, really well. And it really is a multidisciplinary team. And I'll just add that I think one reason it works really well is because at our institution, vascular surgery, vascular medicine, interventional cardiology are all, and cardiothoracic surgery are all under the same umbrella in the same institute. I know other places it's not the same. And so I wonder, I have a 2-part question, real quick. One is, do you think this is generalizable to institutions like that, where it's more diverse and the leadership is not under the same umbrella? And 2 is that, the methodology you mentioned works really well with patients who are in the outpatient setting, and major amputation has been discussed and decided upon. But what about in the hyperacute setting, when a patient shows up to the ER, an outside hospital, for example, with acute limb ischemia? Is it the same process? Is it different? Do you have to modify it somehow?
Thank you, Ian. Thank you for your nice comment and question. Yeah, I think, I think this is, can be applied to all institutions, regardless of the model of that institution, whether, vascular surgery, interventional under the same umbrella, or they're different, they're different, kind of one under medicine, one under surgery. I think as long as, you have the right people who have the passion and dedicated to care about the patient. But again, I'm pretty sure there's a lot of logistical and cultural carriers, maybe in other institution, but I don't think this should be a problem. If you have the passion, you want to collaborate, I think everybody should be able to do the same. Now, the other question was about, I'm sorry, what was the other question about?
In the hyperacute setting with acute limb ischemia, patients presenting with the ER, how does it work?
You're right, yes. So, most of the time, whoever receives the first, consult or page about this patient, they would evaluate, at least I can speak at our institutions, they would evaluate the patient promptly and then consider, first the options that they would treat the patient with. And if they think there's maybe a better option, they would probably either we call vascular surgery or they call us. We really work along side to side very, very, very well, to be honest. I'm very proud of our system for that reason.
Thanks, Tarek. Tony, you have a comment, buddy?
Yes, congratulations. Yes, great talk. And sounds like you have a very impressive outfit at UH. I wanted to ask, so who ultimately is responsible for the patient once you guys, obviously you guys, it sounds like you guys have mobilized very quickly, provide the care needed for the patient, but let's just say 2, 3, 4, maybe 6 months down the road, who is responsible for follow-up on that patient after you've implemented your care?
Yeah, so it would be most of the time would be the one who had performed the revascularization procedure. And of course, that one would be depending on their availability. You know, once the team assemble, you know, whoever is available, thinks they can get this done, etc., will get prior to do the case, and you know, would be responsible to follow up the patient in the outpatient setting.
And do you guys facilitate access to prevention? For example, like you said, you get a lot of referrals from the outside, and their expertise might not be in vascular medicine. So do you guys also provide that too?
Yes, yes.
Outstanding.
Thank you, Tariq. Before we move on to new advances in polyvascular disease research, and Tony takes it over, I want to make one comment. I hope my colleagues on the panel agree that on one end, while it is important to outline the tremendous morbidity and mortality associated with critical limb ischemia, on the other hand, it is also important to identify and clearly say it aloud that progression of claudicants to CLI is actually not common and quite rare, and therefore a preemptive endovascular or surgical revascularization, primarily endovascular in claudicants for the purpose to prevent CLI is actually not a viable thing to do. And I think we really need to speak out about it as much as we do in terms of the overall burden of critical limb ischemia. So Tariq, you made some wonderful points. I hope we're able to capture and ask you some important questions. I also want to put in a pitch for the last part of our discussion after Tony is done, where we will discuss at least a specific case, because I think that's the biggest challenge, an elephant in the room, how to apply this evidence to a particular patient. And we're going to have some case-based discussions, and I will start out with a case, and I think my panelists will add their own clinical experience to it. So before we go on to that part, I think, and without further ado, I want to invite my esteemed colleague, Dr. Tony Gutierrez. I can tell you about him. He's a modest guy. He's going to speak about research, but by himself, he is actually a very, very qualified and a very successful researcher, successful in writing grants. He's a tremendous writer, and I've read his grants and drafts. And Tony, you don't have to blush. You're a phenomenal writer, and has been extremely successful in both competed in competitive grants at the national level. So Tony, you are best suited to tell us about future research and avenues that we should be looking out for in the coming years.
Well, let me start off by saying I'd like to thank CVI and Dr. Banerjee for the opportunity to speak tonight, and also the kind words that my check is in the mail. I'm going to be talking about new advances in polyvascular disease research. I have no disclosures pertinent to this talk. So over the next 9 or so minutes, I have been tasked to bring you up to speed on new polyvascular disease research. And in order to do that, we're going to hit 4 areas: genomics, gene expression, inflammation, and implementation. So why don't we start off with genomics? So recently, using an EHR, investigators were able to perform a genome-wide association study using the Million Veteran Program. Now here, they were able to find and include at least 31,000 patients with PAD and over 200,000 patients as controls. Interestingly, they found 19 PAD loci. Now, these loci were verified using the UK Biobank. Now, 18 out of these 19 loci were brand new, meaning they had never been identified before. Now, some pretty interesting things I'm going to show you right now. 11 out of these 19 foci were associated with atherosclerosis in all 3 vascular beds: peripheral, coronary, and cerebral. If you look at the breakdown of these loci, the ones in blue, 4 of them, were associated to lipids. 1, diabetes, 1, the hypertension, and 5 were unknown. Why is this important? Well, we now live in the era of gene editing therapy, right? So this has a huge potential over the next few years as a target. Plus, these loci coincide with everything that Ian told us earlier in this session, right? We talked about lipids and inflammation. These are all things that will target current therapies, and we need to enforce for prevention in this high-risk patient population. Let's jump over to gene expression. Here, in this study that was published last year, RNA sequencing was performed in symptomatic PAD patients prior to peripheral vascular intervention. Now, they took 42 PAD patients and compared them to age and sex matched controls. They went ahead and performed differential expression analysis. And what they found was 127 differentially expressed transcripts. Out of these, 40 were associated with an increased risk of cardiovascular and limb events after PVI. To take it one step further, they were actually able to validate one of these in a mouse PAD model. So as providers for patients with polyvascular disease, why do we care? We now have an ability to identify high-risk patients who have the potential to get adverse events in multiple vascular beds. So it now gives us a target to provide these therapies you heard about earlier to get these into these patients as soon as possible. Let's switch gears a little bit. Let's move on to inflammation. To do that, we're going to talk about the safety, tolerability, and efficacy of canakinumab on leg artery structure in patients with PAD. Now, this therapy is an antibody that interrupts the interleukin pathway. Pretty interesting study. It was a small 39 patients, and to no surprise, what this medication did in patients with PAD, it lowered high sensitivity CRP. This is the ratio compared to baseline on the left panel. Canakinumab is in red. In blue, we have placebo. And what you can see, you see a lowering of these levels at every point, every 3 months. The stars indicate a statistical significance of p-value less than 0.05. Same trend for interleukin 6. You see a decrease in levels at each of the points 1, 3, 6, 9, and 12 months for those treated with canakinumab. However, let's take it one step further. What I think is interesting here is they also looked at functional status. On the left panel, we have a change from baseline in maximum walking distance. Again, canakinumab in red, placebo in blue. And what you can see that there was an improvement from baseline in maximal walking distance, reaching statistical significance at 3 months. On the right, we have a change from baseline in pain-free walking distance. Again, in red, study drug, you can see statistically significant improvement in at 3 and 6 months. So we now have a therapy that will now lower inflammatory levels, which we all know are associated with atherosclerosis, but also have the ability to improve functional status in patients with PAD. Granted, this is a small study, however, it shows a significant amount of future potential. Last, but definitely not least, this is where I think in the next 5 years, we're going to see an explosion of research, and that's in implementation. And I'm going to show you why. To do that, we're going to have to look at the high intensity lipid lowering strategy after ischemic event studies. This comes from our colleagues in Colorado, the Pcsk group. And what they did is they looked at data from the market scan database, over 250,000 of patients with PAD, and they investigated to see which one of these patients had data on lipid levels, and those subsequently followed them for 18 months. On the left side, on the y-axis, we have percentage of patients, and on the baseline, what we have on the x-axis, we have those at baseline, those that had no events, ended up having CLI, major adverse limb events, and MI or ischemic stroke. Now, a high-intensity lipid-lowering therapy here was defined as either having a high-intensity statin, being on a statin and ezetimibe, or being on a PCSK9 inhibitor. This figure shows me two things. The first thing is that we so far do a very poor job in putting these patients on high-intensity lipid-lowering strategies. Even those that had no events, only 26% out of those that did. Remember, Dr. Banerjee reminds us that it is a rare event, but still only 38.5%, 41, and 55. But what scares me even more is the bottom line here. Here we have percentage of patients with LDL less than 60. At initial presentation, about 25%, same with those that had no event. But take a look at those that had the worst outcomes that are concerning for our patients. CLI only 36.6, male 36, MI and ischemic stroke at 41%. What this tells me is that just placing our patients in a high intensity lipid lowering strategy is simply not enough. We need to combine the therapies that Ian talked about earlier in this presentation about antithrombotics. We need to use all of the tools in our armamentarium. So, future directions. I think it's going to continue to be in genomics. Remember, we now have gene editing therapy, gene expression to help highlight higher risk patients. We have anti-inflammation and implementation. For the first time, and I would say in a decade, we have really great studies, large randomized controlled trials, giving us really good therapies such as PCSK9 inhibitors, Revascularization, antithrombotic therapies that really show a significant benefit in this patient population. What we need to figure out is how to get these therapies into the hands of our patients. Thank you.
Tony, fantastic, short and sweet. And I think that you have hit research areas that are clinically quite relevant to our audience, because I'm sure there are other areas of polyvascular and PAD research that are more on the basic side, that I think you have highlighted those that are going to make a change, a difference to our clinical application. So I think the implementation research is a great segue to the next section. Let me share my slide, because this is a really exciting session for many reasons. Number one, we are going to be able to hold the recommendation made by our faculty and hold them to fire to make some commitments here. And I think this will get the juices flowing in those who are joining the webinar, and the chat room is hopefully going to burst open with the comments and exclamation marks. But I think that is exactly the intent. I in particular, let me share my conundrum and dilemma. Despite knowing the evidence I do have a relatively easy time, dealing with patients who are post-revascularization, like Ian said, and that's kind of the area where most of our interventions happen, both on the medical side. That is an opportunity. But let me share with you this specific patient, and starting with Ian, then Tariq, and then Tony. I won't make any commitment because I just be the arbitrator of this. That was just a joke. But after that, in the remaining time, I ask each one of you to outline one common scenario where you see there is a missed opportunity. So there's a presentation I give, PAD, a missed opportunity for cardiovascular intervention. And I think this is a slide and a case presentation from that I'm using here. So this is a story of a 62-year-old man. And if any parts of this patient's case is a real case, a recent one that you need to know in addition to what I've described on the slide, please ask me. I'll be hopefully able to fill it in or get back to you in a short while. It's a story of a 62-year-old male who has prior history of ischemic stroke 4 years ago. It's not a major stroke. He's not disabled by it. There was transient dysarthria, but he recovered fully. He does have a history of also a non-STEMI and acute ACS, for which he underwent right coronary artery intervention 2 years ago. And currently he's off his P2Y12 inhibition therapy. His other risk factors and history include type 2 diabetes, hypertension, dyslipidemia, and a history of tobacco use for about 25 years. His medications are shown here. His exam shows a normal cardiac exam. His vascular exam reveals bilateral carotid bruise and a symmetrically decreased dorsal pedal and posterior tibial pulses, though his feet are warm with normal capillary refill and preserved motor and sensory functions and no ulcerations. His clinic blood pressure is 140/80. Ankle brachial index on the right and left that was done at the vascular clinic about, this was 6 weeks ago. Right is 0.8, left is 0.78. No PVR was performed at that time. His total cholesterol is 170. His HDL is 40, and his LDL is 77, and no other biomarkers were performed, including Lp(a) and other forms of therapy. So I think seeing this patient who is reasonably doing well, doesn't have any acute complaints, is here for a follow-up. He's 62 years old, relatively young, has got premature atherosclerotic heart disease. His family history, let me tell you, is not very pertinent. Nothing strikes out that we should go after some sort of genetic testing and do Lp(a) and Lp(a) testings in this particular human being, individual. So what would be the next approach? We leave him alone. We think about more intensifying high intensity therapies, both on the lipid lowering side and the thrombotic side. You want to reintroduce ticagrelor based on the Pegasus study and all other options that would be viable here. So let's start with Ian. Ian, let's put your recommendations to fire here and see if we can get people excited by your comments.
Sure. So this patient is the perfect scenario for secondary prevention of polyvascular disease. There are multiple areas where I think that we can attack to be comprehensive as possible. So first of all, I'll just point out the obvious things. First of all, blood pressure is not at goal. Our goal in these individuals is less than 130/80. That's from multiple trials, SPRINT included. Also ACCORD would show that even though that patients with diabetes, those with less than 140/80, there was a question of whether or not there's additional benefit with lowering, but the current guidelines suggest there are. And so that's one area I think I would try to be more aggressive. Certainly from a lipid standpoint, his LDL of 77 is quite above goal. Less than 70 is ideal. But in this patient who has polyvascular disease, the ESC guidelines may recommend that less than 55 would be a potential goal. And so there are many options, including doubling his atorvastatin, adding ezetimibe, or PCSK9 inhibition, either with the monoclonal antibodies that we have, evolocumab or alirocumab, or even now, the small interfering RNA and glycerin. Thirdly, I think from a diabetes standpoint, we didn't talk about this here, but two novel classes of medications, SGLT2 inhibitors, as well as GLP-1 receptor agonists, play a very important role with coronary and disease and heart failure risk reduction. Although that initially canagliflozin had a black box warning with limb amputation risk in those with PAD, that is now removed. And so I think the general consensus is across the class that these medications are not only beneficial, but indicated in these situations. So there are multiple different areas there. And then finally, you could consider the ticagrelor. You mentioned Pegasus. So low-dose ticagrelor in patients with diabetes has been shown to reduce recurrent events. And certainly here, that's an opportunity to do that given his recent PCI 2 years ago for NSTEMIA and risk, and the data that I showed from the other trials. So yeah, I think there's lots of things potentially to add here. There is polypharmacy that is a big issue with a 62-year-old gentleman with multiple medications, but I think that being as targeted and aggressive as possible with the mortality improving medications is probably the best bet we would go at.
Tarek, my job is to ignite and detonate Ian's recommendations. So Ian just made a recommendation that he's going to add or consider 4 different classes of medications. I mean, I beg to defer that this is unrealistic. And let me just put it, and I'm being, this is my job to trigger people to I hope, Ian, you don't mind it, because that is exactly my role. So Tarek, you're going to send your vascular patients to Ian's clinic. He's going to come crying back to you and say, look, my life is ruined. My pocketbook is ruined. I can't afford it. And you're going to call and pick up the phone and say, Ian, please spare me, because this patient So what are you going to pick out of all the recommendations of PCSK9 inhibition, SGLT2, maybe intensifying his antihypertensive therapy, maybe add a small dose of diuretic or increasing his lisinopril dose, whichever is the choice you make. And then also considering low dose rivaroxaban. So out of which, what are you going to pick? You're going to just take it lying down, or you're going to pick up the phone and kind of.
I think you got muted by.
Yeah. I'm saying, are you going to stay quiet and be docile and take this, or pick up the phone and challenge Ian on this one?
I think I'm going to ask for his help. He put a lot of great options. To be honest, some of the medication, like empagliflozin, etc., were not as comfortable, as familiar. To be honest, the truth to be said, as an interventional cardiologist, I don't think we prescribe as much as we should. For this patient, I think you're right. He's a very high-risk polyvascular. 2 events already. One is ischemic stroke. One is a recent non-STEMI 2 years ago. I think Xarelto 2.5, in addition to his aspirin, might be a very good option. Now, for his PCSK9, I think LDL of 77 is not ideal. I agree with you, but it's close. I think probably I would look for opportunities for lifestyle modification, which might help with, if it's not already optimized, which probably are not, to be honest, the truth to be said, in the real practice, many of these patients are still obese, overweight, they eat junk food, they smoke, they don't exercise. So I would look for these first to optimize his LDL and his blood pressure. Maybe Xarelto to be considered, and empagliflozin, to be honest, I would be calling you. I have not prescribed many of these medications.
So Tony, Tarek took the polite route out. So you are not from the same institution, so you can go after Ian. So what are your recommendations? Do you agree with Ian? You guys are too good to be true. Let me tell you that. But hopefully you will challenge him here.
Well, I absolutely agree with everything that Ian say, but what I would do is, at least at our institution, I would not implement. You're absolutely right. The patients would yell at me probably if I tried to implement everything at once. But I don't think I could implement everything at once if I wanted to. For example, I don't think I could get them on a PCSK9 inhibitor, because at least at our institution, we'd have to bump the atorvastatin up at least to 80, add ezetimibe first, right? And wait 3 months, maybe see the LDL panel. And once that came back, maybe not below 70, then I would probably add the PCSK9 inhibitor. But I would argue, I would make an extra point that I think we haven't spoken about this, just as important. I want to know what this patient's functional status is, because you're right. He has an elevated blood pressure. His ABIs are low, but we don't know what they turn into once they start ambulating, and that will help also improve everything else. So I would want to see what their functional status is, and maybe get them in some exercise therapy.
Excellent. Let me. I think those are all great recommendations. Thanks, Ian, for that. Taking all the harassment from all of us. But I think you are absolutely right that this patient, although is a very routine patient, and you would agree that in many circumstances, this patient would get a pass. They would say, everything is good, sir, shake hands, and you are ready to go. Blood pressure seems kind of there. The LDL goal is kind of there, but nothing is that optimal. And I think recognizing these areas of unmet need was the real intent behind this question. Now, another challenge that we face in our system, at least in ours, is that it is very, very hard to kind of quantify the risk of these patients. So in the remaining few minutes, first of all, I want to share this 2020 ACC Expert Consensus Decision Pathway. I'm sure this is a very valuable document. This is in addition to the guidelines, and I think this outlines some of the more recent evidence on how to implement them, and takes quite a structured approach in terms of providing choices. For example, it does speak about the various appropriate doses of antithrombotic therapies if a patient has atrial fibrillation versus a patient has secondary prevention for polyvascular disease and using rivaroxaban for 2.5 milligrams BID instead of the 20 milligram dose. I think those are important areas. Second is the combination of P2Y12 inhibition, and which P2Y12s especially are easy to combine and have good data with with the NOACs, which I believe is mostly clopidogrel, and other nuances that are quite important. Now, at our institution, what we are doing is looking at a risk calculator for secondary prevention. And what this is a European Smart Risk Score that has taken 13 very easily available through EMR factors. The only one that is not easy to find is the high sensitivity CRP. But if you go down this risk calculator, and I've included a link here, but you can search by Smart Risk Score Calculator, you can actually apply this score quite easily without this HSCRP value. And what it does, it helps categorize and quantify the patient into various risk categories. What we use for more simpler implementation is use low, intermediate, and high, and not break them down into 5 groups as shown here, but into 3 groups. This is easier to digest, and then use it as a EMR tool so that the EMR can pull and provide this integrated score. And this is a validation study. This is about 20,000 patients from our institution, where we calculated the Smart Risk Score in 2003 when they were first referred to the cardiology clinic. And we categorized those patients, and we then estimated their observed mortality from those. And you can see how well the Smart Risk Score predicts these. And after this initial validation, we have now applied it to about 470,000 patients, a publication that is about to be due. And I encourage, if any one of you are interested in collaborating, I think this will be a fantastic score. And what our institution has done has included Smart Risk Score and the HASBED bleeding risk score as part of the EMR tools, where you can estimate this. And the advantage is that starting from primary care to subspecialists, everybody applies the same scoring system. So this kind of gives polyvascular disease a number. And I think that it is not so much important, but I think for greater adoption and universal acceptance, I think you can then decide, where this patient is. And I think that this patient I calculated, and this is his Smart Risk Score. You can see the patient I just cited, he's actually in the Smart Risk Score category that is quite high. And Ian made that extremely clear when he first identified the subtle off-target measures this patient has. And I think that is why I encourage everyone to consider this, and maybe we can start a movement where this becomes the mainstay. There are not many secondary prevention scores. It's not easy to find that are applicable to this setting, that use variables that are easily discernible from EMR screening. And you can see, and for implementation research, Tony, that many of these values could be easily derived from the EMR, and a composite score could be represented for a patient with or without the HSCRP. So I think we are getting towards the end. We have about a few more minutes. I want to invite my colleagues to share their final thoughts about any specific take-home messages from their institutions that we have probably not hit. There are so many, but maybe some very sentinel points, how they organize their secondary prevention clinics. Starting with you, Tony, any insights on implementation, because you have studied it and also practiced it?
One of the things that the Durham VA is we have been successful is actually embedding the risk score into CPRS. And I think I was going to ask you, how do you get the SMART score out aware of the providers? And that would be one great way to make it a mainstream, and somehow it's connected to the actual note, and it comes up there and it's highlighted by everybody to see. But that's a pretty.
We have actually integrated the Smart Risk Score under the tools section of the CPRS. We are right now working on getting our EPIC programs at Parkland and Clements on board, so that there is, for the fellows, there is a universal way of doing this. But I think that would be a good implementation project for us, and hopefully, we'll get you all also excited and participating in this. Maybe pool our data, and that would be quite meaningful. Ian, over to you. Any final thoughts and parting thoughts and words of wisdom?
Sure. As a preventive cardiologist, I am always struck by how we miss PAD, and we miss opportunities for screening for PAD, whether it's just for simple exam to check pulses, or ABIs for screening. But I mean, I think all of the talks today were very clear that polyvascular disease, we should not just be focusing on the coronaries, we should be focusing on the entire cardiovascular system. And these are missed opportunities here for patients where they could be under the radar, and without asking, without checking, we're missing opportunities for risk reduction. So I really appreciated everyone's talk, and it just gave me a new resilience and enthusiasm for going out and treating these patients.
And also that you have plenty to do in your life, given the fact that this is such a big problem. Tarek, your parting thoughts?
I agree with all of you, and I think, again, recognition and detection and referral, and Yang can, attest, we have at UH, I think he's directing the cinema program, or he's co-directing the cinema program, which specializes in people with risk factors, diabetes, obesity. It's a multidisciplinary team to take care of such complex patients, so I think also marketing, right? Because, not everybody is aware of the program. You need to market for the program. You need to get referral, take care of patients. So there's a lot to be done.
I have been trying to, I didn't put up that slide, but I'm trying to populate right from the end of my fellowship about 18 years, 20 years ago, where I wanted to populate interventions for PAD on a slide. And I used to have like 3 or 4 little boxes, and now that has grown significantly. And due to significant efforts from our colleagues from various parts of the country and various parts of the world, and I think we are at a point where we can offer our patient meaningful interventions, both in terms of device-based intervention, revascularization options, and also a very, very effective and powerful and life-changing medical therapies. And I think this has been a wonderful session, and thank you for all our faculty for being really precise and to the point. I can't thank you enough for sharing your evening with us, and also the audience for keeping us honest by some of their provocative comments. I'm sure we'll hear more of them. The recording of the entire session will be available on our website, www.cvinnovations.org. Is also posted widely on YouTube and social media. And finally, you can all, the attendees can and faculty can, of course, earn their CME certificates by going and logging on to our website. See you all live in Denver. Until then, goodbye and good night.